I thank SFM for this opportunity. Special thanks to Sani sir, Sabu sir, who has inspired us all these years. So the topic is basic and additional plates for fetal cardiac evaluation. Uh, if we finish all this, we'll see some normal variants, and in the end, we'll see some cases of where there is normal four-chamber view. Abnormal cases with normal four-chamber view, because abnormal four-chamber view will be dealt with in the next talk by my friend Dr. Vishnu. So basically, whenever we go for the heart, we have to start from the stomach. They say the way to a man's heart is through stomach. So the same thing applies for the fetus also. So we have to start from the stomach. We'll basically deal with all these views. First is stomach, then four chamber, LVOT, RVOT, three vessel view, and finally three vessel trachea view. We'll move from the abdomen to the superior mediastinum in a sweep. But life is not so simple. For RVOT and LVOT, you have to rotate the probe slide, as just mentioned by Sani sir. So first situs, I'll just repeat what sir told. We have to, it should be a clockwise arrangement of the stomach and the umbilicoportal vein if the fetus is in vertex presentation, and anti-clockwise if the fetus is in a breech presentation. Similarly, if the in transverse lie, when the fetal head is in the right maternal flank, the arrangement is again clockwise, and anti-clockwise when the fetal head is in left maternal flank. You can also imagine yourself in the place of the fetus, or you can place a toy to reduce your time. This is situs solitus. Situs solitus is basically a normal situs which we all have. Situs inversus is a mirror image. If we see that clockwise and anti-clockwise think totally opposite, then we'll see situs inversus. And finally, there is something ambiguous. If we don't know the situs, like in this case where the heart is on left, stomach is on right, and we are not sure what is the exact situs, then it is called as situs ambiguous. So once we are done with the situs, then we can move to the heart. So in abdomen along with situs, we should see few important structures like aorta and IVC. Aorta is to the left of the midline, closer to the spine, and IVC is to the right and slightly anterior. That relationship is important, especially to diagnose right and left atrial isomerism, where there is juxtaposition and the progressive sign. So once we are done with the situs, we'll move to the four-chamber view. Four-chamber view can be, depending on the position of the spine, the four-chamber view can be, it can be apical, lateral, and basal. And of course, in apical, you can see color. Sir has just told that color is now part of a basic guideline. We can see a nice laminar flow in apical four-chamber view in color also. In apical four-chamber view, we will deal with all these points, starting from situs and size to contractility and rhythm. I will not repeat them because we are going to see all these one by one. That is the clip of apical four-chamber view, and we'll see how it works. First of all, situs and size. Situs we have already seen. In a normal heart, the cardiac apex we all know should be on the left side, and heart should occupy 1/3 of the thorax. Remaining 2/3 is occupied by the lungs. Cardiothoracic circumference ratio is 0.45 17 weeks, and 0.05 term, and cardiothoracic area ratio will range between 0.25 to 0.35. Here you can see this is a case of dilated cardiomyopathy occupying more than 50% of the thorax. Cardiac axis again it is 45 degrees plus minus 20 degrees, and that can be right axis deviation, left axis deviation. Right axis deviation is generally because of extra cardiac anomalies pushing to the heart, pushing the axis and the heart, whereas left axis deviation is cardiac anomalies like conotruncal anomalies. We can see this case almost the cardiac axis is 90 degrees, and this was actually a case of top. So four-chamber view will throw you just one abnormality in top, that is an abnormal axis. That picking that hint, you can move ahead and then evaluate the heart further. So then cardiac position, 2/3 of the heart is towards the left, 1/3 is towards the right. If it is in the center, it is called mesocardia. If it is in the left, it is levocardia. If it is in the right, it is dextrocardia. You can see here case of chaos, where the axis is almost straight, and it is mesocardia. And these two cases where the heart is shifted to the other side because of diaphragmatic hernia and CPAM. So when we say dextrocardia, we should be aware of two different terms. One is dextroposition, one is dextroversion. Dextroposition is position of the heart is towards dextro, that is right side. So, but the cardiac apex will still be pointing towards the left. It will be because of the diaphragmatic hernia, pleural effusion, etc. Whereas in dextroversion, the heart is in the right, cardiac apex is again in the right, and it is seen in sidecardias, inversus, and mid-tronics. So now coming to both atria and interventricular septum. Both atria should be of equal size. In heart, everything is equal. Atria, ventricles, they should be equal almost. And left atrium is the most posterior chamber. Pulmonary veins open in the left atrium, and foramen ovale also opens in the left atrium. Whereas in the right atrium, SVC, IVC, and coronary sinus opens. Interatrial septum is formed of septum primum, septum secundum, and the foramen ovale. Same holds true for ventricles. They should be of equal size. And the right ventricle is the most anterior chamber, just beneath the sternum. It is crescent shaped, slightly short, tabaculated, with irregular cavity. Moderator band is extending up to the apical region, in contrast to the left ventricle, where the moderator band will go and attach to the wall of the ventricle. And left ventricle is most left-sided chamber, conical shaped. It is a smooth walls, and cardiac apex is formed by left ventricle. Interventricular septum, few words about the interventricular septum. It separates right from the left ventricle. It is thick at the apex, thin at the AV walls. Apical 2/3 is muscular, and lower 1/3 is membranous part. And when septal defect is suspected, it is good to see in the lateral floor chamber view, and IVS is best visualized in lateral floor chamber view. Normal thickness of IVS is 2 to 4 mm, and it could be thickened in case of hypertrophic cardiomyopathy, which could be seen in diabetics or some other abnormalities. So you can see this case of, it is over 14 Beaker. In this gray scale, you can see just subtle finding of defect in the interventricular septum, and whereas the color shows that it was a muscular vein. Again, coming to atrioventricular walls. Atrioventricular walls are a dynamic structure. Basically, heart is a dynamic structure. That is what it differentiates it from a few other structures like Gray knots. AV walls will prevent flowing of the blood back to the atria, and there is an offset of the AV walls, which we all should see. It is a normal variant. It's a normal thing. And tricuspid wall will be between right atrium and right ventricle. Mitral will be between left atrium and left ventricle. And we should see the normal opening and closing. And crux is a midline structure formed of 4 things: septal leaflets of both AV walls, septum primum of the interatrial septum, and membranous portion of the IVS. And this is what happens when the crux is absent. That was the case of AVS. Now coming to pulmonary veins and area behind the heart, this has caught the fancy of fetal cardiologists all over the world in last few years. So the structures basically in the area behind the heart are, you see these 2 pulmonary veins. Basically there are 4 pulmonary veins, but we will see just 2 in case of 4 chamber view, and that is good enough because we have ruled out total anomalous pulmonary venous connection. Partial anomalous pulmonary venous connection can still occur, but that is not life threatening. So we have done a job by looking at 2 veins at least, and that is the aorta, slightly towards left of the spine, and that is the azygous vein, and that hyperechoic structure is the esophagus. Esophagus can also be physiologically and pathologically dilated. That also should be looked after. This was a case of TAPVC. You can see the pulmonary veins are not joining to the atrium but to joining each other. There is a twig side, and the area behind the heart is increased. That is the importance of looking beyond the heart actually. Contractility and rhythm. Right and left ventricular contractility should be equal without any paradoxical movement of the interventricular septum. FHR we all know it is 110 to 180 and should be regular with no extra beats. You can see this extra beat here. That was a case of premature atrial contraction. M mode is a very underutilized thing in our armamentarium, which I feel, and it should be used more because it not only gives abnormality of rhythm but chamber size, pericardium thickness, interventricular thickness, and many more information. Coming to LVOT, it is the first outflow tract which will come across as we move ahead, and the aorta will arise. It will not branch immediately, and just look for the septo-aortic continuity and the aortomitral continuity. Septo-aortic continuity, when you have established, it rules out any type of VSD, malalignment, overriding, and you have practically ruled out many abnormalities, especially colorectal anomalies, if you have just seen this one section. And aortomitral continuity is just to establish that aorta is actually arising from the left ventricle and not from right, as we might see in few cases like DORV and TG. Coming next to RVOT, as I told, we have to rotate the probe slightly towards the fetal left shoulder to get a better view, and RVOT will branch immediately after its origin. It will cross over the aorta, and the right branch will course behind the go behind the aorta. Now coming to further up, if you go, then we see three vessel view. Three vessel views are basically pulmonary, aorta, and superior vena cava from left to right, and pulmonary artery will be seen in longitudinal section, whereas the other two vessels are seen in transverse section, that is line dot dot, which means that many speakers use that abbreviation. And the size of the vessel is the pulmonary artery slightly larger than the aorta, and SVC is the smallest. Color should be in the same direction because both are going away from the heart, and whereas SVC will show opposite direction because it is going towards the heart. Few cases of abnormal three vessel view. The first one, this is normal. Here you can see just two vessels. So this could either be CAT or TGA. In CAT it should be a bigger diameter and of the vessel, and TGA it should be normal because both vessels are present. The only thing is it is not seen in your section. This case, narrow RVOT, you can see, dilated aorta. There was a case of cough. Here you can see the reversal of flow in narrow aorta, and whereas the pulmonary artery is slightly dilated. There was a case of HLHS or aortic atresia, I would say. Here the aorta is small diameter, but there is forward flow. So this could be seen in case of interrupted aortic arch coagulation or hypoplastic aortic arch. Now next we see a narrow pulmonary artery with reversal of flow that can be seen either that can be seen in case of pulmonary atresia. There are two types we will just see in the next section. Here you can see the grossly dilated pulmonary main pulmonary artery and right and left branch that is seen in pulmonary wall syndrome. In the end, you will see few clips of this. So abnormal three vessel view, if we see small aorta with forward flow, it could be interrupted aortic arch coagulation or hypoplastic arch. Small aorta with retrograde flow, it could be seen in aortic atresia or critical aortic stenosis. That is HLHS. Small main pulmonary artery with antegrade flow is seen in TOF. Rarely you can see retrograde flow in TOF also, which is called as a blue type TOF. And small MPA with retrograde flow will be seen in three cases. First is critical aortic stenosis, second is PAVSD. PAVSD is pulmonary atresia with VSD, and the one is pulmonary atresia with interventional vessel. Then markedly dilated MPA, which is for the last case in the previous slide, absent pulmonary wall syndrome. Only two vessels are seen in CAT and TGA. Depending on the size of the vessel, we can differentiate the two further. DORB type of TG will also show two vessels. Four vessels can be seen in PLSVC. This is a normal variant we've seen in isolation. That is persistent left SVC. That is basically the fetus will have two SVCs, right and left both. And this is TAPVC. We just saw a case of TAPVC also, and where we saw a widened area behind the heart and the pulmonary veins joining each other, not to the atrium. Three vessels, it's a normal thing, and rarely you can see PLSVC and a normal right SVC, absent normal right SVC. That will again give three vessels. That is again a normal variant. So coming to three vessel trachea view, if you go further up, then we will see three vessel trachea view. There is ductal arch, aortic arch, SVC from left to right. Again, both of them will unite towards the left of the spine and will show the same color. Abnormal three vessel trachea view, few examples. This is normal. Here you can see this vessel coming out of the junction of the two vessels and going behind the trachea. That is arsa. This is right aortic arch. This is double aortic arch. This is a video clip of double aortic arch forming a whole circle around the trachea. This fetus is made present with a stridor and a respiratory abnormalities after birth. So finally, this is a complete sweep starting from the abdomen, going to the four-chamber view, and first we will see this four-chamber view. There is LVOT, there is RVOT, three vessel view. And finally So now additional views. Additional views are basically three, and all those are sagittal views. So we'll start from the right. The most right one is right parasagittal view. There is bicupal view, also called as hammock view. SPC and IVC are seen draining to the right atrium. SPC will open in the right atrium, and it will be in continuity with the intra-atrial septum. IVC opens in the right atrium with the flap, that is eustachian flap. This view is important, especially in right atrial aneurysm, where there will be a continuation of the IVC. Aortic arch. This is the mid-bang mid sagittal, almost slightly to the left. View you will get. We will see a arch arising from the center of the heart. It is acute circular curvature. It will give away three branches. Brachiocephalic artery, which will further divide into carotid and subclavian. Then left common carotid and left subclavian. And beyond this is the aortic isthmus. There is a potential site for coagulation of aorta. Ductal arch is the leftmost, and it will arise from the superior aspect, that is from the ventricle, right ventricle. It has wide angular curve, hockey appearance, does not give any branch, and connects with the ductus arteriosus. So this is again a complete switch. I thank Dr. Vishnu for this beautiful clip. The unit started with ductal arch, this is the aortic arch, and finally we have come to bicupal view. So fetal heart, you can go have a look at during anti-scan also. All the views can be actually seen. The video of fetal heart is almost formed during the anti-scan. Only thing is that it is small in size. Plus we might miss out on few evolving anomalies which appear in second or third trimester. That is the only difference. Otherwise, nowadays with the new machines, we can see quite a few anomalies in the anti-scan also. That is 4 chamber and that is 3 weeks. Normal heart at 14 weeks, you should see bare minimum is this. You should see tricuspid flow, as Sani sir told in one of his talk, that if ever you want to use a spectral Doppler, use the tricuspid flow, so that you get FHR, you get EA waves, you get any regurgitation which you can detect. Then this is the inflow of the two chambers, and that is the outflow. Just one case we will see of abnormal 4-chamber view in abnormal heart in first trimester. This was 12 weeks, 3 days, and you can see there is hardly any flow going to the left ventricle. That was hypoplastic left heart syndrome. Patient continued with the pregnancy. This is the same patient at 20 weeks. Beneath you can see the reversal of flow in the aorta seen in the first trimester as well as second trimester. So spectral Doppler is also important to complete your cardiac evaluation. This is the mitral valve showing PA. This is how the valves spectral flow of pulmonary and LVOT will be seen. Generally, the peak flow velocity is between 50 to 90 centimeters per second, and beware of the angle. It should be as close to zero as possible, but sometimes it is not possible to try to be between 0 to 30. This waveform is unique. This is of ductus arteriosus. You can see two triangles, alternate triangles, one bigger and one smaller. That is the unique flow of ductus arteriosus, and that shows it as continuous forward flow. This flow is something similar to ductus venosus, but it is not so. It is the flow of pulmonary veins, which mimics the flow of ductus venosus actually. S, D and A waves we have systole, diastole and aortic. Finally, the tricuspid flow, which we all discussed just now. EA ratio is important. It should be less than 1. If it is more than 1, then it will suggest IUGR and poor prognosis. Secondly, it will give information about tricuspid regurgitation. Also, tricuspid regurgitation can be in first trimester it can be a marker of aneuploidy. In second trimester it can suggest IUGR or cardiac defects like tricuspid dysplasia, abstinence anomaly, etc. 2 or 3 abnormalities of the spectral Doppler. This pulmonary vein Doppler was taken in case of HLHS. It shows reversal of the flow in the A wave. This was a case of PAIVS, and these are dilated ventriculocoronary arterial communications, VCAC. They show again a bidirectional flow, and this was a case of the same case that TAPVC. Here the pulmonary vein will show monophasic flow like a typical vein anywhere in the body because it is not directly communicating with the heart. Few words about cardiac biometry. So you can measure the aortic valve, pulmonary valve just at the level of the cusp. Similarly, you can measure the mitral and the tricuspid valves also. And whenever there is any abnormality, fetal biometry will come to help you, because sometimes one vessel is great vessel is smaller and other is larger. So we are not sure whether this vessel is shorter or that vessel is dilated. That is where the fetal biometry and Z score comes to your rescue. So there is a long list of fetal biometry. Once you find an abnormality, all your protocols and basic guidelines should be kept away and do a fetal detailed biometry. All these charts are free available on perinatology, and in advanced machines they have an inbuilt chart for Z score nowadays. So once you find an abnormality, you can't stick to the basic protocols as just said by Sari sir. Now few normal variants. This is echo dropout artifact in apical foot chamber. Beware of this. This end should be echogenic in case it is a real VSD, and lateral foot chamber will come to your rescue, where it will show that it is not there. Again, you can have echo dropout artifact or a hypoepic area in lateral foot chamber view. But again, this is the area where the coronary arteries arise. That's why it appears like that. And secondly, it is beyond the aortic wall. So that echogenic intracardiac focus, we all know, if it is seen in isolation, it is a normal variant, because if you agatho-Claus likelihood ratio, if you go, then a single echogenic intracardiac focus will keep the risk unchanged. So it's just a calcification of the papillary muscle, and it is more common in Asian population. So in isolation, but when you label echogenic intracardiac focus, when you see echogenic intracardiac focus, most of us focus on the heart itself. That is a good thing, but you have to see the fetus in toto, because you have to see for the aneuploidy markers like that, mild dilatation of ventricles, mild dilatation of the pelvic system, etc. etc. But heart has been allotted two factors in that likelihood ratio. One is echogenic intracardiac focus, and another one is ARSA. So that is the only structure which has got two. Now, few more pitfalls. Pericardial infusion less than 2 mm can be a physiological thing. See, this is abnormal. Few more discrepancy in the right and left heart size can be normal in third trimester, but before labeling it as normal, you have to do a thorough evaluation. Even in third trimester, as sir just told, that you should detect anomaly in any trimester. PLSVC is the commonest venous anomaly. Both the veins will show the same color, in contrast to PAPVC, where the extra vessel will show opposite color because it is going away from the heart. Secondly, coronary sinus is seen dilated in such cases. It should be differentiated from ASD. In coronary sinus, as I told, that the flow will be towards the right atrium, whereas in ASD it will be away from the right atrium. That is a differentiating point. Plus, these cases are associated with coarctation of aorta. If you want to be safe, just advise fetal echo in third trimester or postnatal echo of the neonate, because it is evolving. Coarctation of aorta is evolving anomaly and has got a strong association with. One more variant is right aortic arch, we have already seen. Double aortic arch, we have already seen. This is not very normal thing actually. It can be abnormal because fetus may present with breathlessness. Few uncommon normal variants. You can see I told that both the atrioventricular walls should show a offset normally, but here that offset is absent. Rarely you will see this. These fetuses have some association with Down syndrome, but if seen in isolation, they are normal. You see this three vessel view, and this is S-shaped ductus arteriosus, that is tortuous ductus arteriosus. It is a normal variant again, except for maybe a slightly high chance of thrombosis. This again I thought was tortuous ductus arteriosus, but when I saw this paper, the measurement came out to be almost 10 mm, and then I took label it as a ductus arteriosus aneurysm. This is actually one case only which I have seen till now, where the heart was normal and still there was mesocardia. The axis is like 0 degree. Anything abnormal here? You can see this. The foramen oval flap going more than half of the left atrium plus hypermobile. That is aneurysm of flap of foramen oval. It is again a normal variant. The only thing is sometimes you will see a narrow left ventricle like in this case. Now coming to cases, I'll show you one case of PAC, premature atrial contraction. This is the video of the same case. You can see the heart is not in the, moving in a perfect rhythm. This was again the double. this is quite simple. You can see both the great vessels arising from the right ventricle. So that is the case of DOR. I just added this follow-up for this one sentence. See this aorta is right and anterior. So that is the importance pediatric cardiologists give to the relationship of the vessels, and we should be mentioning it even in our antenatal scans. This is quite a simple case and commonest one. You can see narrow RVOT and a dilated LVOT plus some overriding there. Yes. So that is tough. Four-chamber view, that is the left ventricle, and the vessel that is arising from the left ventricle is branching. So that was a case of parallel vessels. You can see this is a glass body image. As I told, once you find an abnormality, you have to go beyond the protocols. So this was glass body just to reaffirm. This was a 3D of the Doppler. Here you can see even our modest grayscale imaging can show you that a branching vessel is arising from the left ventricle. So that was the case of TG. TUI you can use along with color also. You can see the parallel vessels here, these two sections. So that was T. As we go towards